Good morning. Welcome back to Oxford School. In the last session, we have discussed about the major cardiac symptoms, that is chest pain, breathlessness, palpitation, syncope and pre-syncope, and peripheral edema. Today, we will discuss chest pain of cardiac origin. Chest pain of cardiac origin is due to myocardial ischemia produced due to narrowing of the coronary arteries. When the coronary arteries are narrow, at rest there will not be any chest pain, but on exertion you get pain, and that typical pain is called anginal pain. The pain of coronary ischemia is felt as a pressing pain, a band-like sensation, as if a heavy weight is kept. Some people may describe it as bursting in time. It is a ill-localized pain, it's a diffuse pain, and many people keep the hand over there like this. An area of the chest of the size of the fist, this is called the Levin sign. The pain is promptly relieved on taking rest or by sublingual nitrates. Or typically this lasts less than 10 minutes. The degree of physical exertion required to precipitate a symptom is a guide to disease severity. For example, somebody on walking 1 kilometer develops pain, and another patient developing pain on walking 50 meters. The second person is having a more severe disease. The anginal pain can be divided into typical angina, atypical angina, and non-anginal chest pain. Typical angina has got three cardinal features. One, it is retrosternal chest discomfort. Of the classic characteristic that I have described. Second, it is provoked by exertion or emotional stress. And third, it is relieved on rest or nitrates within minutes. This is called the typical angina. If two are there, it is called atypical angina. And no features are there, it is called non-anginal chest pain. A typical angina has got a very high likelihood of having a coronary heart disease. So, the chest pain of ischemic origin we describe as anginal pain. This can be stable angina, unstable angina, or myocardial infarction. Myocardial infarction causes symptoms which are similar to angina but more severe and prolonged. Clinically, pain lasting more than 30 minutes. We can consider it as a myocardial infarction. This is associated with severe restlessness, breathlessness, and feeling of impending death. This is only pain that produces a patient a feeling that they are going to die. That is a feeling of impending death. The anginal pain typically radiates to the right arm, inside of the right arm, inside of the left arm, the root of the neck to the epigastrium. So these are the typical areas of, and same radiation can occur in myocardial infarction also. Usually the patient has got associated symptoms like nausea, vomiting, and profuse sweating. The pain lasts less than 20 minutes but more than 10 minutes. Usually we call it as unstable angina. Unstable angina and myocardial infarction are called together as the acute coronary syndrome. The pathophysiology is different, that will be discussed at a later time. In myocardial infarction, there is a complete blockage of the coronary arteries, whereas in unstable angina, there is a dynamic occlusion. There is a clot is formed, and a clot is lysed by the intrinsic fibrinolytic mechanisms. That we will study later. Another pain which due to cardiac cause is the pericardial pain. Pericardial pain is typically constant anterior chest pain. This can radiate to the shoulders. It tends to be more sharp and stabbing in nature and can have some pleuritic element also. It may be that is, it can be exacerbated by inspiration. The pain is typically relieved by sitting, leaning forwards, and can be aggravated in the lying down position. And the most common cause of pericarditis are viral infection, connective tissue disease like SLE, polymyocardial infarction. So that is called the post-myocardial infarction syndrome, Dressler syndrome, after surgery, catheter ablation, or radiotherapy. Another important pain that imitates myocardial infarction is aortic dissection. That is a tear in the intima of the thoracic aorta. Is a life-threatening condition. It is often missed. This is an abrupt onset, very severe pain. It is tearing in nature, maximum in the beginning, and it goes to the back, radius typically to the back, in the scapular region. 90% of patients report the pain as the worst pain they ever had. The onset is often, as mentioned, it is abrupt. The myocardial infarction, usually the pain starts and it goes to a peak. Such pain is very unlikely to be due to dissection. If the tear involves the cranial arteries or upper limb arteries, there can be associated syncope, or the patient can develop stroke or asymmetries in the pulse and blood pressure. The difference in the BP between both upper limbs is called, or both upper limbs can occur, it is called anisospasmia. It is usually the right radial artery pulse will be weak and the left will be present. So it is important to examine. When you are examining, you should examine both pulses. The predisposing factor for dissection, the most important condition you remember, is the Marfan syndrome. A family history of aortic disease may be there, or non-aortic valve disease, previous manipulation of the aorta, or history of a thoracic aortic aneurysm. So when you get a chest pain, you think in terms of OPQ or STA. O stands for the onset, P stands for the position of the pain, Q stands for the quality, R stands for aggravation relieving factors, S stands for the severity of the pain, T the time, how long it lasted, what happened later, S for the A stands for the associated symptoms. The associated symptoms can occur along with a cardiac pain, usually breathlessness, palpitation, syncope, sweating, nausea, vomiting. These are the common symptoms. Again, you should remember, chest pain can be due to various other causes. A chest wall problem, a herpes zoster, a skin disease, musculoskeletal problems, like trauma you can get, or costochondritis, pleural problem, that is pleurisy. So think anatomically, starting from skin, soft tissues, musculoskeletal tissue, pleura, pericardium, and myocardium. The approach to a patient chest pain will be discussed later. The next session will be discussing about palpitation. Thank you.